I'm super excited because it's been on my bucket list for about 10 years now to go to camp. So I get to go to camp this year. And so thank you to the organizers for inviting me, and a big thank you to my wife who gets to take care of my 2 kids while I get to play at camp. All right, let's see if this works. So these are my conflict of interest. So basically what you'll see is pretty much every company that's working in Fabry disease. I always tell people, if you're working in Fabry disease, I want to be there to help you go the next level. This is not a sponsored talk, which means I get to say whatever I want. All right, so these are the objectives. So why is this? So just as an introduction, I am a nephrologist by training, but what happened about 12 years ago when I came back to University of Alabama at Birmingham, my mentor, Dr. David Warnock, called me up and said, "Hey, do you want to do Fabry disease?" Because we'd had one patient together, and I said, "Sure." It was my first job. I didn't know anything about Fabry disease, and I've just loved it ever since. And so currently, not only do I run the Fabry clinic, where not only I'm the nephrologist, but I become the primary care for patients with Fabry disease. But we've expanded that to all rare disease. So rare genetic kidney disease is now what that clinic is. And we take care of about 105, 110 patients with Fabry disease. So it's a very large clinic, and really one of the my favorite activities. But today I'm going to be nephrology. I'm going to put my nephrology hat on and answer some questions. So these are the objectives. So why is the kidney important? How does it work? How do we measure the effects of Fabry disease on the kidney? What can the kidney tell us about Fabry disease? And then how can I keep my kidney function stable? And why are these the objectives? Because these are the questions my patients ask me. All right, so we just learned about the pathophysiology. So obviously, Fabry disease stems from a genetic mutation. There is over 1,000 mutations that have been described in the GLA gene. When you don't have alpha-galactosidase, stuff builds up in the lysosome, and then the sum total of those cells that are diseased actually causes organ dysfunction, which then leads to problems. So really what I tell my patients is that the lysosome is like the stomach of the cell. So imagine if you did not have stomach acid, what would happen is all this stuff would build up and you wouldn't feel so good. Well, that's what happens in the cells, and eventually this actually causes organ dysfunction. All right, so why is the kidney important? So who cares about the kidney? Well, the kidney is important because it does a lot of stuff. So if I wanted to summarize, it provides balance. So our body makes a lot of trash all the time. We put trash into our body all the time. And what the kidney is able to do, it's able to get rid of the trash that we don't need and keep on the good stuff that we do need. So it removes toxins. Some of those toxins we just ate, right? So you eat stuff, you don't need all the bad stuff. So you eat too much potassium. Let's say you drank a gallon of orange juice. That's a lot of potassium. If you have normal kidneys, no problem. Your kidney just pees out the potassium you don't need. It keeps the potassium you do need. It removes water. So imagine if you just drank. So most of us drink about 2 to 3 liters of water a day. If you drank that and it went nowhere, eventually you would drown. So that's what the kidney does. We can actually drink up to 14 liters of water a day. That's the excretory capacity of the kidney, and nothing would happen if you have normal kidneys. If you don't have normal kidneys, you have to drink far less than that. And sometimes people need dialysis to remove the water that we drink. So water can be a toxin. All right, it regulates blood count. So most people don't know that the kidney has sensors in it, so that as your blood count actually drops, the kidney secretes a hormone that says, hey, bone marrow, you need to make blood. When that goes away, guess what? Your blood count drops and you get anemia of chronic kidney disease, right? So lots of stuff. It regulates bone metabolism, specifically vitamin D. So vitamin D has to be activated. It is activated in the kidney. Vitamin D helps your bones. It helps your parathyroid, etc. The kidney regulates all that. And finally, it is the master regulator for blood pressure, right? So all of this stuff managed by the kidney. All right. So how does it work? Well, it's just a pool filter. I tell people I'm the pool boy. So basically what you have, and do I have a laser here? Yeah. No, I don't have a laser.
The little star looking thing.
This thing, it's not, I don't think it's working.
Oh, it works this morning.
That's okay. So any pool filter, right, has an intake. So you have bad water going into the filter, then it goes through a membrane of some sort, right? Then good water goes back to the pool. And then there is one other thing, right? So that is the renal artery taking blood to the kidney, renal vein taking blood away from the kidney, getting clean blood back into the blood supply. And then there's a backwash, right? So the backwash is all the bad stuff that goes out. The backwash tube is your ureter, which goes to the bladder, which ultimately goes to the toilet. So if you have a good filter, right, the pool looks like that, which is somewhere we'd all like to be right now. If you have a bad filter, the pool looks like this. Well, you don't want your blood to look like this. Now, it doesn't actually turn green, but this is just the analogy. But the toxins that build up are mainly urea. That's a byproduct of protein synthesis, and it causes you to feel bad. And when your kidneys fail, what most people feel is nausea, almost every day, nausea, vomiting, they lose weight. We know all of this because we didn't have dialysis in the United States as a country until really the late 60s, when Nixon signed the ESRD Act and gave dialysis to the entire country. So what we know about the natural history of patients who need dialysis that don't get it is because there was a time where we didn't have dialysis. But the hope is we can prevent you actually needing us to supplement your filter by doing a good job in taking care of your Fabry disease. So just as the analogy, this is the kidney itself. And what you have is the renal artery takes blood to the kidney. That's the filter. The renal vein takes the clean blood back to the body. And then the ureter is the backwash. Now, it turns out that the kidney is made up of 1 million glomeruli. So the glomerulus is on the right, and basically the glomerulus is just a small kidney, and it has the same form. I mean, it's crazy. You have an efferent arteriole that brings bad blood to the tiny glomerulus. You have an afferent arteriole that brings the clean blood back to the renal vein. And then you have a backwash. I mean, so, it's just crazy. You have a big kidney, and then each big kidney has 1 million smaller little kidneys called the glomeruli. Right? Now, every filter, so when you have a filter, you have to have a membrane, right? So that's how filters work. So think about sieves, right? So, who makes mashed potatoes, right? So, when you make mashed potatoes, the idea is I have pressure, right? That's gravity, pulls the water and the potatoes down into the sieve. The water comes out and the big stuff stays on top, right? It's the same thing with the kidney. You have a sieve in your kidney. The big stuff is blood and protein, right? So that is what you don't want in the urine. If you get potatoes in your sink, there's a hole in your sieve. That's a problem. That's the same thing with protein, right? So what is the sieve made of? The sieve is made of 3 layers. One is a fenestrated endothelium. That is your blood vessels. So the cells that line the blood vessels, and they have holes. It is fenestrated, just like a sieve. Then there is this mesh of proteins called the glomerular basement membrane. That is just proteins that are all interwoven together, largely made of type 4 collagen. And finally, you have these cells that are, honestly, they're beautiful. They're called podocytes. So podo means foot, cyte means cell. And so these podocytes they look like octopi, right? And so what they do is the body of the podocyte is that big thing on the bottom, or see that big glob? But that glob has little projections. Those are the feet. And they wrap around the blood cells, forming a third barrier. That is the podocyte. And that is largely where we know that Fabry or GB3 inclusions start even at birth to start accumulating. When you're born, you have pretty much all of your podocytes. You don't get new podocytes. They don't regenerate. So that is why when we biopsy people, we look for the podocyte because it's been there the longest. So it's had the longest time for these cells to actually accumulate. All right. So how do we measure the effects of Fabry on the kidney? Well, these are things that you need to talk with your doctor about and you need to understand, right? So number 1 is a creatinine. Now, the creatinine, we plug into an equation, and that equation gives you what's called the glomerular filtration rate, or GFR. And the way I explain the GFR to patient is that's the percent that your kidneys are working, right? Now, fortunately for us is that, if you were if my kids bring home a C, I'm like, oh man, you got a C, that's bad. But 70% kidney function, we were born with way more kidney function than we ever needed. And, just to illustrate that, we ask patients to donate a kidney. We take out an entire kidney from somebody and that person does just fine, right? So 100% is what you want, right? But if you don't have 100%, it's not severe. So what did we just hear from the last presentation? Severe was less than 30%, right? So usually what I tell people is, look, if you got 30%, you got everything you need, but you don't have any reserve, right? Anything above 30% is what you have to lose before you start having issues. People don't actually need dialysis until 10%, right? Usually we start looking for transplants about 20%. But we want to keep the reserve there, right? It's not to say, oh, don't do anything until your kidneys get to 30%, but just know that if a doc gives you you have 60%, it's not the end of the world. You say, how can I stop it from getting worse? I have everything I need. I got 30% to spare, but I want to keep it that way, right? All right, so the equations that we use are called the CKD-EPI equation. Now, most institutions now have switched to the CKD-EPI equation. There's probably still a handful that use the MDRD equation. So you also want to know what is the equation that they are using to calculate your GFR, all right? So CKD-EPI is what you need. And I believe you guys are going to get these slides. All right, now, creatinine is made by muscle, right? So creatinine has nothing to do with the kidney other than it's made by muscle and it's peed out at a constant rate by the kidney. So if my kidney stops working, the muscle keeps, nothing changed with your muscle. So the muscle keeps dumping creatinine into the blood and then the creatinine value goes up. Now, the reason that's important is people with less muscle mass will have lower creatinines for a lower GFR, right? So low is good in creatinine, right? So I'll give you an example. My baseline GFR should be about 0.9 based on my size and muscle mass, right? A female of my same size and build, because on average, females have less muscle than men, will have the same kidney function that I do with a creatinine of 0.6. Now, why is that important? It means that females, by and large, get diagnosed at a later stage of kidney disease, right? So because, docs are humans, right? And so when we look at things, we look at the H, right? When does the lab say H? High, right? So the high value for creatinine is based on males and females, right? And it's usually 1.2. So when a female has a 1.2, I start saying this is a problem. When a male has a 1.2, I look and say it may be a problem, but what's their build? So that's why specifically males are probably okay in this equation. Females really need to say, what is my GFR? Do not base this off of my creatinine. I want to know my GFR. Okay. All right. So creatinines, yeah, we talked about that. And then the other things that we can look at is protein in the urine and podocytes in the urine. Now, podocytes in the urine, it'd be great because podocytes actually slough into the urine and you can measure those. That is only a research test at this point. You can't just go and order that from LabCorp or anything like that, right? So, but we can look at protein in the urine. So why do we look at protein in the urine? Because the more potatoes that are in the sink, the worse the filter is, right? And we need to fix it. All right. So this is just an equation. This is an illustration of what happens with the creatinine specifically in females. So what you'll see here is the creatinine value is in yellow, right? Now, we start at 0.6. So this is a calculation for a 30-year-old female, right? So you start at 0.6. And that is the CKD-EPI equation is in blue. The MDRD equation is in red. Okay, these are two separate equations. The MDRD equation we did not report it over a GFR of 60, right? So the CKD-EPI shows that this patient has 120 at a creatinine of 0.6, but the MDRD says it's normal, just greater than 60. Now, the creatinine goes from 0.6. Look what happens when you go to 0.9, right? So the GFR has dropped to around 70%. The MDRD equation says everything's okay, right? It's greater than 60, but we are still not high under creatinine, right? So now you have a patient whose kidney function is deteriorating and almost lost 40% of their kidney function. And the MDRD equation nor the creatinine have identified this patient as somebody with kidney disease, right? All the way up to 1.2. By the time the patient's at 1.2, now they're 60% kidney function by CKD epi. Now maybe the MDRD is starting to say maybe this patient does have kidney disease, but we're behind the 8 ball because they've lost 40% of their kidney, 40 or 50%. So this is the reason why you need to know your GFR and you need to know it by CKD epi. Okay, now it turns out that we don't want to wait until somebody has kidney dysfunction before we start treating them. Right? So what do we have at our disposal to say, look, by the time somebody starts losing kidney function, I just showed you how much reserve kidney function we have. So by the time the creatinine starts going up, there's some major problems in the tissue, right? So what if we looked at the tissue first, right? And so we recently looked at our female data, females with relatively normal lyso-GL3, GL3, and normal creatinines. And when we did kidney biopsies, we showed a lot of damage. Why did we show a lot of damage even though the creatinine was normal? Well, first of all, the creatinine is a poor marker in females. But the second thing is that these GL3 deposits and the histology happens first. So as you accumulate GB3 in your kidney cells, you start getting damage. That damage leads to fibrosis. And it's only at the later stage of this tissue damage where I actually start seeing a functional change in my kidney function, which means it started to decline. We've already heard the earlier you start, the better you do. So that's what we need to go by. All right. So now what can the kidney tell us about Fabry? Well, the first thing, in order for the kidney to tell us something, we can do proteinuria and you can do creatinine. That's great. That tells us that your kidney is not functioning well, or it is functioning well, but it doesn't tell us that things are necessarily normal. So a lot of times what we do is a kidney biopsy, right? So now, we don't do kidney biopsy on every single person, but there are definitely indications, right? But I want you to know about kidney biopsy just in case somebody recommends one, right? So what's the procedure? So you have 2 kidneys. They're located in your back. They are about that far down, depending on your abdominal girth. So the larger you are, the further down they are, but they're pretty close to the back, right? They usually lay you flat on a table with your stomach face down. They do not put you to sleep. Right? The reason they don't put you to sleep is every single time you breathe, your kidneys move. We don't like to hit a moving target. We like them to stop. So at the time of the biopsy, they say on the count of 3, 1, 2, 3, hold your breath. You hold your breath. The kidney stops moving for while you're holding your breath. We click a button. It goes in and out of the kidney, and we get a piece of your kidney about the size of the head of a pen, right? Like a ballpoint pen. It's tiny. We usually do that 2 to 3 times. Now, before they do the biopsy, we also numb you up. The kidney itself has no nerve muscles, but the skin or the fascia around the kidney has nerves. So we dump a bunch of lidocaine right on it so you don't feel it, but you need to be awake for the procedure. Now, if this was not invasive, we'd say, well, do a kidney biopsy on everybody, right? But it turns out it is invasive, right? So what are the risks, right? Now, all of the risks with a kidney biopsy are bleeding. So bleeding, bleeding, bleeding. Why is it bleeding? Well, the kidney filters blood and it gets 1 liter of blood per minute, right? That is a lot of blood. It gets 20% of what's called the cardiac output. So when I put a pinhole into a sac of blood vessels, bleeding is the issue, right? Now, the first thing we tell about risk is that everyone will have blood in their urine when they get a kidney biopsy. That is normal. That just means they got kidney. Right. I've had one patient where it wasn't personal. A friend of mine told me about a patient. They didn't get kidney, they got liver. So you actually want blood in your urine after a kidney biopsy because it means they got your kidney. Right. The second thing is, so about 1 in 1,000 patients will bleed to the point they need a blood transfusion. Right. But it turns out that's not really true. That is all comers. So when we biopsy, most patients that we do kidney biopsies on, we biopsy them late. So CKD stage 4, CKD stage 5, where the blood vessels already have a lot of calcium built up in the blood vessels. So imagine putting a hole in a PVC pipe. It doesn't close up, right? So when I put a hole in somebody with advanced CKD, they are more likely to bleed. The other thing that happens in advanced CKD, I just told you the kidney adjust blood counts. So if I start with a blood count of 9, I only have to bleed to 7 to get a transfusion. If I start with a normal blood count, then I have a much longer way to go before I need a transfusion. So all this to say, the indication in Fabry patients usually is to biopsy way earlier than our standard biopsy, which actually reduces your risk, right? So the next one is you can bleed. If you continue to bleed, let's say you continue to bleed, they can actually go up, find the artery that's bleeding, and then cauterize it. But I have never, ever had that happen in a Fabry patient, right? So anyway, there are risks. It is actually relatively low risk when you look at early CKD. Now, everything has benefits, right? So the benefit of not doing a kidney biopsy is you don't have to have a kidney biopsy, right? The risk of not doing a kidney biopsy is we don't know what's going on in your kidney. And in some patients, we really need it to make a treatment decision, right? Now, the risk so the benefit of doing a kidney biopsy is, well, we might be able to help some people out. So these are things that I think probably need kidney biopsies. All right, so what is the significance of a variant mutation or late onset mutation? So, a lot of people think this is binary, if Fabry, then treat. But the problem is, and as many of you know, is that the treatment is not the easiest of treatments, right? I have patients, some of them getting 5-hour infusions, right? Every 2 weeks. Now that is a lot of time commitment. So we not only need to answer, should we treat, but when should we treat? Does every late onset mutation need to be on enzyme at the age of 5, right? The answer is probably not. So what we do is we biopsy and we say, well, you don't need it right now. Your creatinine is normal, your baseline evaluation is normal, and your kidney biopsy doesn't show that much damage. But then we're going to follow you yearly, and then as we'll identify it early so that we can actually start it when you need it, right? So that late onset variant. So many of you may have been diagnosed with variants of unknown significance. Now, the problem is the American College of Genetics says do not use variants of significance to treat patients. So I don't, but I biopsy them, right? And many times variants of unknown significance, when I get the genetics, are of significance because I do a kidney biopsy and they have GB3 all throughout the kidney, right? I had a patient recently misdiagnosed with multiple sclerosis, had a variant of unknown significance, so she had white matter in the disease. We biopsied her kidney. Sure enough, she had Fabry disease in her kidney, which meant that her multiple sclerosis was not multiple sclerosis. It was all Fabry disease. So now females, the problem with females, you guys are complicated, which is that, females, even sisters within the same family, same mutation, and I have two families like this. One female has 0 symptoms, 0 inclusions on biopsy. The other female has angiokeratomas all over her body, severe pain in her hands and feet. And you say, well, clearly you don't necessarily have to treat just because you have a genetic diagnosis. So just like the late onsets, you say, not only do I need to treat, but when do I need to start treatment? Both of those questions are important and can be aided with a kidney biopsy. All right, scarring and prognosis. So, a lot of times, and I tell nephrologists this, the kidney biopsy is not just about, do I have Fabry disease? We know you have Fabry disease. You got the genetics, right? And we know that most of these folks, most of you will have inclusions in your podocytes because they started building up from birth. So I don't care if you have inclusions. What I care about are those inclusions actually causing damage, which we grade by scar, which is called fibrosis, which we can see on the biopsy, and foot process effacement. So those podocytes, as they get damaged, they spread out. They become, they were nice and rounded on that biopsy, but they actually spread out, and it's called foot process effacement. That is histologic damage. So now I know you have Fabry and it is causing damage in the tissue. Now, some more practical reasons for kidney biopsy is insurance, right? So meaning that I had one fateful summer where an insurance company stopped 4 of my female patients on their enzyme. And I said, why did you stop them? They say, you did not demonstrate that their lyso-GL3 was getting better. I was like, but they had next to normal lyso-GL3 to begin with. So females, a lot of times, will have low levels of lyso-GL3. It's a lot easier statistically to show something that's really bad gets better than it is to show something that's already close to normal gets better, right? So the good news is I was able to talk with somebody with a brain, and I said, all of these patients have had a kidney biopsy, and I don't care what their lyso level is. I'll show you their tissue is destroyed. They need enzyme. Insurance reinstated it for everybody, right? So lyso-Gl3 is a great marker, but it is not fantastic when it comes to females. Specifically, we have females that have next to normal levels of lyso and they still have disease. So, all right, the only other thing is that more rare, we are identifying that patients, so proteinuria is actually pretty common, Fabry is not. So we have identified patients that actually have something else. So I'm able to, since I see this all the time and I'm a nephrologist who does rare disease, sometimes there are patients whose kidney function is declining, right? But it is declining much, much faster than I would predict for Fabry disease alone. So this is about not just knowing my kidney function is getting worse, but it's getting worse very quickly. Or the protein is nice and stable, but then it jumps way up. And I say that is not Fabry disease. So those patients we do biopsies on, and we have identified other things. We have one patient who had lupus and Fabry disease. There are at least 7 published case reports of membranous nephropathy and Fabry disease. So just because you have Fabry disease doesn't mean you can't get the other stuff that the kidneys get. But unfortunately, I've encountered many nephrologists that say, well, the kidneys, or I call it falling off a cliff, kidneys declining very quickly, but you have Fabry disease causes that. And I'm like, it does, but not at that rate. We need to make sure that it is Fabry disease. So let's see. All right, all right, so when we do a kidney biopsy, what do we see? Well, we see these things called zebra bodies and whorls, right? Now, it's the same thing, meaning that it's an onion. So when these things build up, they form an onion. So everybody's cut an onion. So if you cut it this way, it's a circle. If you cut it this way, it's stripes. That's zebra body and whorls, right? That's how we treat people. Now, interestingly enough, Fabry disease is not the only disease that causes this. So if you have this on kidney biopsy, so I get emailed from people across the country about kidney biopsies. And one of the most common things is we had a kidney biopsy. It is chock-a-block full of these things. We did genetics. They do not have Fabry disease. Enzyme activity level is normal. Lyso-Gl3 is normal, right? What do they have? It's almost always a drug. So there are drug-induced phospholipidoses, right? And so most recently, some of the drugs that do this, the most common, amiodarone and hydroxychloroquine, right? Now, imagine just, the history, right? Fabry disease patients have pain. Sometimes they get misdiagnosed as rheumatoid arthritis, which can be treated with hydroxychloroquine. And now you get these. So it turns out patients with Fabry disease don't do as well if you are on meds like hydroxychloroquine. Amiodarone is another one. And most recently, coming up strong in 2021 was sertraline, which is Zoloft, which inhibits other phospholipases. So these are things that, although they can mimic Fabry disease, we also probably don't want our Fabry patients on them because it's a twofer. All right. So let's just take you through just an actual case, right? So we have a 31-year-old female with family history of Fabry. She just presents for evaluation because, her dad had it. She wanted to get tested, right? So she has just occasional mild pain in her hands and feet, but lots of things cause pain in the hands and feet, right? She denies angiokeratomas, so she doesn't have any of those little spots. She has no skin lesions. She has no GI symptoms, and she sweats fine, all right? So no, we did testing. She has classic mutation, but she doesn't have, and she's like, why would I don't need treatment. I'm fine. All right. So we continue. We do the baseline evaluation. Everybody gets a baseline evaluation, right? So we did a cardiac MRI and an echo. So a lot of times insurance companies won't let you do the cardiac MRI without the echo. You're going to hear from John Jeffries today, who is the expert in this. But cardiac MRI really is your gold standard. Normal left ventricular mass. That means the heart size was normal. She had no late gadolinium enhancement. That is very specific to Fabry disease, meaning scar in the back of the heart. So MRI of the brain, she had no white matter disease. So basically, your evaluation is pretty good, right? Her CKD-EPI is 99. So that means she has normal kidney function, and she has a 24-hour urine that shows she does not have protein in the urine, right? This is a good evaluation. All right. So what did we do? Well, based on our experience, we say that doesn't mean she doesn't have Fabry disease, right? She may actually have real Fabry disease. So we did a kidney biopsy. This is what her kidney biopsy looked like. So all of that dark pink, right? So the normal is the light pink. This is one glomerulus, right? Remember, you have 1 million glomeruli. This is one glomerulus. The dark pink stuff shouldn't be there. That is all globotriacyl ceramide, right? So it just goes to show how much kidney reserve you have, right? But if we let this keep going, she won't have normal kidney function. And if this is going on in the kidney, it's going on in all the tissues of the body, right? Because the mutation is not kidney specific. It's going on in the nerves. It's going on in endothelial cells, risk of stroke, all of that, right? So this is what her electron microscopy looks like. You have the zebra bodies and the whorls. So guess what? We were able to start her on therapy. Now, why are females so complex, right? I mean, why can I have the same classic mutation and have such differing presentations, right? And it turns out it's something called lionization of the X chromosome. So you don't need 2 X's, right? So what each one of your individual cells do, it decides. It says, all right, I am a cell, I'm going to use this X. The neighbor decides I'm going to use the other X, right? And it should be random, meaning 50-50, right? So 50% of your cells use one X, 50% use the other. And it is the sum total of those cells that creates the organ, right? So, but it turns out it's not that easy. So some females have 80%. So we have a test that can actually detect what's called skewed X inactivation. So imagine I'm a female and 100% of my cells choose the X chromosome with the Fabry mutation. Well, now all of a sudden I'm as severe as a male because every one of my cells has Fabry, right? Now, if I'm, on the other hand, a female where 100% of my cells choose the normal X, now all of a sudden I have 0 symptoms. I have the mutation, it's a classic mutation, but it's not activated because it is epigenetics that is causing that. So it's not just genetics, there's epigenetics and other things, right? So this is a study, it's probably the best study that's been done. There's been 4 studies that have been done on lionization of the X chromosome, but this really showed the importance of it. And so what you'll see here, this is GFR. So the people who were skewed, the females who were skewed towards the normal had the highest GFRs. The people who were 50-50 had GFRs in the middle, and the people who were skewed towards the Fabry had the lowest GFRs. So that is why even with a genetic mutation, you still don't know what to do with a female, right? So sometimes kidney biopsies help with that. All right, so how can I keep my kidney function stable? And I'm okay with time? All right. So I'm going to tell you everything that's out there. All right, so treatment. So I always divide treatment into Fabry specific treatment. You know, a lot of docs want to say if Fabry, then X, right? But it turns out there's Fabry specific treatment directed at the pathogenesis of the disease, and there is Fabry adjunctive therapies, right? So there's other stuff that we can do for Fabry that is not enzyme, chaperone, et cetera, that you need to do in addition to Fabry specific therapies, right? All right, so enzyme replacement therapy. So right now, Fabrazyme has been FDA approved for patients who are 2 years of age and older, right? So Fabrazyme changed the world for Fabry disease. In 2003, before 2003, you know, I think of 2003 kind of like late 1960s with dialysis patients, right? So before 2003, it's like, oh, you have Fabry disease, good luck, you know, and I've had patients, that's exactly what their doc told them. Good luck, you know, it's not going to be a pleasant ride, right? 2003, we got Fabrazyme and truly changed how we manage patients. Now, what we do know about Fabrazyme is the earlier you start it, the better patients do. And just as an attestation, I have a 40-year-old male with a classic mutation who got started at the age of 20 and still has a normal kidney function, a slightly enlarged heart, but nothing what the natural history of this disease should be, right? Now, patients who got started later on 40 and 50 tend to have worse disease and don't respond as well, but they do respond some, all right? So Replagal, it's approved in other countries. We don't have it in the United States, so I'll just leave it at that. And what got so if you guys know the history, so Fabrazyme was conditionally approved until 2 years ago. Actually, I think it's 3 years ago now. And the reason is the FDA said, we need more data, we need more data. There was one study that came out and it pushed the FDA over, which was this, and it showed that Fabrazyme slowed the decline of kidney function to 2.46. All right. So that's good. But what does that mean? What does this 2 mean? Right? Because a lot of patients say, I don't know what that means. This is what it means. So if I have, so these are just slopes, right? So I told you that people need dialysis. Yep. Okay. Yeah. So I told you that people need dialysis at 10, right? If I have a slope of a line, I want to know where does that slope intercept 10, right? So if I have a GFR that is declining by 9 per minute, right? 9 per minute per year. That means I'm losing 9% per year. That's the green line. That is, if I start with normal kidney function, in 14 years, I'm going to be on dialysis, right? Now, if I slow it by 3, so I go from 9 to 6 per year, now all of a sudden I'm going to be on dialysis in 21 years, not 14 years. That is 7 years longer without dialysis. That is what a slowing of a kidney function decline by 3 means. Now, if I go from 6 to 3, I go from 21 years to 39 years, right? Now, huge. So tiny changes. When you're talking about a slope of your kidney function over a lifetime, small changes have huge impacts in the amount of time that people are not on dialysis, right? What we like to achieve is no slope, because 2 parallel lines never intersect, right? Which means I don't have to talk about dialysis. All right. Now, there are some therapeutic challenges. So it has definitely changed the world for Fabry, but there are some therapeutic challenges like infusion reactions, right? Now, there's ways to treat infusion reactions. So we can do steroids, we can do Benadryl. We've gone so I've had patients on Singulair, I have patients on Claritin, I've had patients on Pepcid and Cromolyn. I've gone as far as using Cromolyn, which is a mast cell stabilizer. But I have males who are on all 5 therapies and they are still having some breakthrough reactions. So it's not everybody, it's not even the majority, but there are some patients that just, that was their life. They knew they were going to get infusion reactions. All right. Now, these infusion reactions are largely thought secondary to anti-drug antibody. We just heard about anti-drug antibody. It's important that you know your anti-drug antibody status. Most of these will be in males, right? Now, females can develop them, but they usually develop them at low titers. But I have had some females that develop antibodies and they do mean something. So everybody should have them checked. We usually check them once a year. All right. Now, there is some evidence that having anti-drug antibodies can actually inhibit the response of the enzyme. But in my experience, that is not until you get high titers. And for me, that's usually in the 1 to 6,000 or 1 to 12,000 range, right? So this is not just I have a very low titer of antibody. It's I have antibodies, but they're there. They're significant. Did you have a question, Jerry?
Close.
Huh?
We're getting close.
On time? Okay. All right. Okay. All right. So I'm going to talk about balance, right? So Elfabrio, it's an interesting name. Fabio, we call it Fabio in our clinic, but Elfabrio. So a lot of patients are now asking Elfabrio as an enzyme. It got approved in May of this year, right? So a lot of patients saying, well, should I just switch, right? What does this mean for me? Because we've never had the paradigm where we had multiple therapies until 2018, which was Galafold. 2023, now we have Fabrazyme and Elfabrio. So what does that mean for me? So it turns out that the balance study design, what they did was they did a randomized, blinded, controlled trial, Fabrazyme versus Elfabrio. So we would infuse patients. We didn't know what they were getting. They were getting the same dose, 1 mg per kg every 2 weeks. And we said at the end of 2 years, let's see what happens to their kidney function was the primary outcome, right? Now, it turns out this on the left-hand side is the graphs of the kidney function. Now, creatinine goes up and down in many patients. So what you want to do is say the sum total. Are those 2 lines, the blue and the orange, different? And it turns out they're really not, right? That is for kidney function, Elfabrio and Protalix, Elfabrio and Fabrazyme met non-inferiority, means that for the kidney, they were identical, not better, identical. They, one was not better than the other. All right. Now, lyso-GL3 overlap. So statistically, there was not a difference in lyso-GL3. So we had more evidence that not one was better, but that they were just as good, right? So off the bat, you say, well, should I switch? Well, right now it's, non-inferior, except for one thing, which was this. So treatment emergent adverse events, but even more importantly, this. So infusion reaction rates, right? So the total number of patients that got infusion reaction, the unique patients was the same, right? But the rate, the recurrence, right, of the infusion reactions was less in the Elfabrio group than in the Fabrazyme group. So what does that mean? Well, the conclusion, I'll stop there because I'm getting the hook. All right, so the conclusion, what we are doing, right, this is my personal practice, is that if you are stable on Fabrazyme and you have no issues with it, you're staying on that, right? Because there's no reason to switch you, right? It was non-inferior. However, if you are the usually male who is on 5 drugs to try and prevent infusion reactions and you're still getting them, which is the minority, those are patients that we say maybe you get a trial, right? You get to switch. Let's just see. Because one of the best things about having new therapies is hope. There is no drug in any disease state that manages 100% of the patients, right? There will always be that someone that says, look, something's not right. We need something else, right? And that's really where I'm excited that before it was, we're just going to keep going. We'll extend the infusion, et cetera. But at least now for some of the patients, we have something else. Same with chaperone therapy that has been beneficial. It's an oral therapy. Now we have trials, which I was going to go over, but don't have time. SRT, substrate reduction therapy. You're going to hear about gene therapy later on. I mean, so every one of these studies we do at UAB, and we do it because it is hope for patients that need hope, right? And I'm a dad, I'm a patient, right? I mean, we all are. So I always tell my colleagues, don't refer to patients, because at some point we're all patients, right? And we all are going to experience something in healthcare, and we all need hope, and that means we need as many new therapies as possible, because we have unmet needs, and there will always be those. So with that, I will be at camp, I think, to talk to anybody who wants to talk to me. And I look forward to it.
Thank you, Dr. Wallace. Appreciate it.